Intraventricular conduction disturbances. Classification of intraventricular conduction disturbances, IVCD. 1. Right bundle branch block, right BBB. 2. Left bundle branch block, left BBB. 3. Left anterior fascicular block, LAFB. 4. Left posterior fascicular block, LPFB. 5. Left septal fascicular block, LSFB. 6. Other types of IVCD. Etiology of intraventricular conduction disturbances. The causes of IVCD are the same causes of AV block. The most common are the idiopathic degenerative conduction diseases and acute coronary syndromes. IVCD affect about 2% of elderly greater than 60 years. Manifestations of IVCD. 1. Aberration, transient block. 2. Permanent or intermittent pre-excitation. 3. IVCD due to drugs. 4. Chronic bundle branch block, chronic BBB. Aberration, transient block. Site of aberration. Aberration can occur anywhere in the His-Purkinje system, but unlike chronic BBB, the site of block during aberration can shift. Right BBB pattern of aberration is the commonest. With heart disease, right BBB pattern constitutes about 80%. While in normal hearts, it constitutes almost 100% of cases of aberration. Mechanisms of aberration. 1. Tachycardia-dependent aberration, also called phase 3 block. 2. Bradycardia-dependent aberration, also called phase 4 block. 3. Concealed transseptal conduction. The following discussion clarifies these mechanisms. Transient block of an impulse in a particular tissue, aberration, is governed by the following two main factors. 1. Duration of the tissue refractory period. 2. Timing of arrival of the impulse to that tissue. Duration of the tissue refractory period. The duration of refractory period created by an impulse during its conduction in most cardiac tissues directly correlates with the duration of the cycle length, CL, preceding that impulse. A golden rule in electrophysiology is that an impulse ending a longer CL creates a longer refractory period, while an impulse ending a shorter CL creates a shorter refractory period. Let us consider a premature ventricular complex arising in the left ventricle, LV-PVC, as illustrated in this figure. This PVC will stimulate the left bundle branch, LBB, earlier, that is after a shorter CL, than the right bundle branch, RBB. Accordingly, it creates a shorter refractory period in the left than in the right bundle branch. One can conclude that premature stimulation of a tissue creates a shorter refractory period, while delayed activation creates a longer one in that tissue. Accordingly, the refractory period of the His-Purkinje system lengthens as the heart rate slows, and shortens as the heart rate increases. This is because with slower heart rate, each impulse is preceded by a longer CL, and creates a longer refractory period, but with faster heart rate each impulse is preceded by a shorter CL, and creates a shorter refractory period. The above description is true for all cardiac tissues, but those having decremental conduction, namely the AV node, the sinoatrial junction, and rarely the bypass tracts. In those tissues, the response is the opposite, a shorter CL creates a longer refractory period, and vice versa. Timing of the impulse. Conduction of an impulse in any tissue depends on the state of its excitability or refractoriness. For an impulse to conduct in a tissue, it must stimulate it, that is, to fire an action potential. If the impulse arrives at the tissue during its refractory period, it will never stimulate it and never conduct through. For stimulation and subsequent conduction to proceed, the impulse must arrive at the tissue after the end of its refractory period. Moreover, conduction velocity of an impulse in a tissue depends on the level of its membrane potential at the time of stimulation, which in turn determines the rate of rise and the peak of phase 0 of the action potential. With these rules in mind, one can easily explain phase 3 block, phase 4 block, and concealed transseptal conduction, as well as certain phenomena such as the gap phenomenon and Ashman's phenomenon. Phase 3 block. With more negative membrane potential at the time of stimulation, more sodium channels are available for activation, with greater influx of sodium into the cell during phase 0, activated sodium inward current. Phase 0 is faster, and its peak is higher, resulting in faster conduction velocity. On the other hand, when stimulation occurs during phase 3 of the action potential, before full recovery and at less negative potentials of the cell membrane, a portion of sodium channels will still be refractory and unavailable for activation. Thus, sodium current and phase 0 are reduced, and conduction is slower. To conclude, phase 3 block, also called tachycardia-dependent aberration, occurs when an impulse arrives at tissues that are still refractory, caused by incomplete repolarization, during phase 3 of the action potential. Phase 3 block can occur at any level of the conduction system, and may manifest as bundle branch block, fascicular block, or AV nodal block. Conditions precipitating phase 3 block. Phase 3 block can occur in normal or diseased fibers, if stimulation occurs under one or more of the following conditions. 1. The impulse is sufficiently premature, such as occurs in aberrant premature beats, an Ashman's phenomenon. 2. Rate of stimulation is relatively rapid, that is, tachycardia-dependent or acceleration-dependent aberration. 3. Prolonged refractory period, whether functional or pathological. Aberrant premature beats. Premature excitation can cause aberration, by encroaching on the refractory period of the tissue prior to full recovery of the action potential, namely during the so-called voltage-dependent refractoriness. Gap phenomenon. The gap phenomenon is detected when delayed conduction in proximal tissue gives more chance for recovery of the distal tissue, which becomes excitable and conducts the impulse. This phenomenon can be seen in any pair of structures along the conduction system, if appropriate relationship occurs between the conduction velocity of proximal tissue and refractoriness of distal tissue, for example, the junction between the AV node and his bundle, or the his bundle and his Purkinje system, etc. Gap phenomenon. In the upper panel, the atrial extrastimulus, AES, seen in the high right atrial channel, HRA, is blocked, and not followed by V-wave in the right ventricular apex channel, RVA. In the lower panel, an earlier AES is conducted to the ventricles, because of its slower conduction in the AV node, which gives a chance for the distal tissue to recover excitability. Effect of heart rate, HR, on the pattern of aberration. Aberration tends to be in the form of right BBB during normal HR, because the refractory period of the right BB is longer than that of the left BB. Accordingly, the impulse may block in the right BB but conducts in the left BB. On the other hand, aberration tends to be in the form of left BBB during faster HR, because with faster HR the refractory period is shortened in both BB, however, the left BB refractory period shortens to a lesser degree. Accordingly, the impulse may block in the left BB but conducts in the right BB. Ashman's phenomenon. Ashman's phenomenon is described during atrial fibrillation, and refers to aberration occurring when a long cycle is followed by a short one, long-short cycle sequence. The QRS that ends the long cycle creates a prolonged refractory period in the succeeding impulse, and the next QRS complex occurs after a short coupling interval, while one bundle branch is still refractory. Ashman phenomenon aberration is explained by two mechanisms. 1. The impulse ending the long cycle creates a prolonged refractory period in the succeeding impulse, and 2. The next impulse occurs after a short coupling interval, while one bundle branch is still refractory. Ashman's aberrancy can be present for one beat and have a morphology resembling a premature ventricular complex, or can involve several sequential beats, suggesting ventricular tachycardia. During atrial fibrillation, AF, or atrial tachycardia, AT. It is to be noted that if an aberrant beat does end a long short cycle sequence during atrial fibrillation or tachycardia, all the mechanisms of abnormal conduction are possible. Ashman's phenomenon, a premature ventricular complex, the probability of which also increases following a long cycle, or concealed transseptal conduction. The differentiation between aberration and ventricular origin is discussed earlier, and here is a reminder. Aberration is strongly favored over ventricular ectopy if the following three criteria are found together. A long short cycle sequence with an initial QRS vector similar or identical to that of the narrow QRS complexes, plus right BBB-like pattern. Ventricular origin is favored in presence of one or more of the following. Absence of a long short cycle sequence. Compensatory pauses. Fixed coupling intervals between normal and wide QRS complexes. Absence of aberrancy despite the presence of RR cycle length combinations that are longer and shorter than those associated with the wide QRS complex. An atypical left or right BBB QRS morphology. Aberration caused by HR acceleration. As just explained, the His-Pourquenier refractory period shortens as the heart rate accelerates, which is essential to preserve normal conduction. If the refractory period of the bundle branch fails to shorten, or paradoxically lengthens, in response to acceleration of the heart rate, acceleration-dependent aberration will result. Restitution. Restitution refers to normalization of aberration with increasing heart rate or persistence of the fast heart rate, which may be explained by greater shortening of refractory period of the bundle branches than that of the AV node, and, or time-dependent gradual shortening of the refractory period of the affected bundle branch. Phase 4 block. Phase 4 block may occur when the impulse arrives to an automatic tissue in phase 4 of the action potential, after the start of spontaneous diastolic depolarization. Similar to phase 3 block, phase 4 block is due to insufficient fast sodium inward current, when the impulse arrives at a relatively less negative membrane potential. Phase 4 block is called bradycardia-dependent bundle branch block, since the long cycles during bradycardia allow for gradual spontaneous diastolic depolarization, and the cell is activated from a less negative potential, resulting in impaired conduction. Conditions precipitating phase 4 block. 1. Faster slope of diastolic depolarization, so that the impulse arrives to the tissue at a less negative membrane potential. 2. Less negative membrane threshold potential, delaying the onset of phase 0 of the action potential. 3. Depressed excitability. Faster slope of diastolic depolarization shifts the membrane potential at the time of stimulation to a less negative potential, for example -50 instead of -70, as seen in this figure. Less negative membrane threshold potential at the time of stimulation, arrow, delays the onset of phase 0 of the action potential. Bradycardia-dependent or phase 4 block almost always manifests as left BBB-like pattern, likely because the conduction system in the left ventricle has a faster slope of spontaneous diastolic depolarization than the conduction system in the right ventricle. Phase 3 and phase 4 blocks in the same patient. Both tachycardia-dependent and bradycardia-dependent aberration can be seen in the same patient with an intermediate range of cycle lengths. The prognosis of rate-dependent aberration largely depends on the presence and severity of the underlying heart disease. Thank you.